axial. Yeah, so we have the CT axial and the coronal images. Any thoughts?
See a lot of free air around the sigmoid colon and extending up along the IMA vessels and into the retroperitoneum. So I'm concerned about like a sigmoid perforation. There's a lot of fecal loading of the colon.
Right, yeah.
And then the rectum looked a little inflamed down there. I don't know. It looks, I don't know. It almost looks like I don't see the wall well of the rectum.
Yeah.
So I don't know if there's like ischemia of the rectum or stercoral colitis that led to upstream obstruction and then perforation.
Yeah, that was it. This is what that like. This was stercoral perforation. So there was no diverticular or anything, but so like post-op, it was all ischemic and necrotic. So, and there were like, as we said, like free air and fecal materials. So yeah, this was stercoral perforation.
Can you show the rectum again? Was the rectum ischemic? Because it does look a little like the wall looks ill-defined. I can't see the enhancement of the wall well. So, but it's interesting because usually stercoral colitis, like you see a big fecal ball impacting the rectum, but this one, I guess, there's just some kind of impaction leading to that rectal ischemia.
Yeah, even the sigmoid, right? Sigmoid also, yeah.
Yep.
Okay.
Thanks.
Yeah. All right.
That's a cute one. Anything that jumps out?
There's like a cystic lesion maybe arising from the seminal vesicle on the right. That thing?
Right. So that's what I thought, right? So the right seminal vesicles look really big. Now.
Oh, he's missing a kidney.
Yeah,
Zinner syndrome.
Zinner's.
Yeah. So this is just kind of dilated right seminal vesicle because the left is absent. Right. So like when I look carefully, there's really, I mean, sometimes we see like in older patients that the seminal vesicle is truly atrophic and like that, but in this case, it's probably absent and the kidney is absent and the right seminal vesicle is just distended because it's doing job for the two.
Cool. Was there a spermatic cord missing in that one too?
Let's see. I don't think so.
No. Oh no. Never mind.
Yeah. Do you want me to continue or?
Yeah, sure.
This is just another cute. So this patient had multiple metastases, get from pancreatic, I think. And at the time on CT, this was noted, right? They said, okay, we see kind of thrombus, and maybe they weren't sure if it's tumor thrombus because it's sitting right next to the central metastasis. So they said, maybe get an MR and we get a better look. And so here's the MR. You can see nicely, this is the vessel, right? So it's T1 hyperintense, sitting right next to that metastasis. We see that there's like the kind of intermediate signal on T2, and you can see the parenchyma surrounding the thrombus kind of edematous, which is not, unexpected. And then here's the portal venous phase. You can see that there's, it's hard to judge, right, if there's enhancement or not because of the, because of pre-contrast. T1 was so bright. Let's see, to quickly get the subtraction here. So here on subtraction, can you see it? Can you see the subtraction?
Yes.
You can see on subtraction that there's really no enhancement.
That's really neat. So it seems like that tumor is probably obstructing the vein. I've never seen such a focal abnormality around it, though. That's really interesting.
So it's T1 hyper, so it's probably like early subacute thrombus. And there's just kind of parenchymal, surrounding parenchymal edema. And you can actually see on EVIS, like on hepatobiliary phase, you can see this geographic, whatever that we saw the edema is also has like diminished function there, which makes sense because there's sort of relatively acute obstruction of flow to this region. So I'm sure that over time this will normalize, but I think we're catching it at like a very opportune moment to see how the parenchyma initially gets affected.
And it seems like since that tumor is causing it or blocking it, they probably don't even need to anticoagulate because it's, like it's auto blocking it kind of thing. And it's just one branch.
Oh, I know. Yeah, I never know. Sometimes they do anticoagulate these, sometimes they don't. So
yeah.
Yeah, that's yeah, okay. Now it's better.
I see more free air this time next to the ascending colon with like bubbly lucencies in the hepatic flexure, like maybe Pneumatosis cystoides.
Yeah. So basically, this was Pneumatosis cystoides. So basically, when we have the cystic spaces along the wall, that is benign, and they say like sometimes they can have serosal cyst and it can rupture and it may have like trace amount of free air, but that's still Pneumatosis coli, which is benign. We should not think of like perforation. And whenever we have the linear air, that is concerning for bowel ischemia.
Nice. Yeah. So this extraluminal air is not really concerning. It's just kind of dissecting into the extraluminal space.
Yeah, exactly. Yeah, because they can have this tiny serosal cyst in Pneumatosis coli. Sometimes they can, as you said, like can dissect into the peritoneal space and, yeah.
Cool.
Yeah.
So this was a rug. I've actually done a few of these recently, and I'm just curious, what do you guys think about this rug?
Yeah. Stricture and irregular, a little bit of beaded appearance, any kind of like your STDs.
Yes, exactly. So this
Gonococcal urethritis.
Exactly. This was gonococcal STD causing multifocal kind of strictures here. So just to review for our residents and audience, this you basically I put a 10 French catheter, Foley into the tip of the penis, and I blew up the balloon in the fossa navicularis to get some tension, and actually then also put like a gauze around the tip of the penis to kind of pull it, so so I can lay it out so I could see the length of the stricture. We have this normal smooth penile urethra, and then we're going into the bulbar urethra. And then here you can see that there's multifocal strictures and narrowing. For us on fluoroscopy, we can't measure and do any measurements unless we calibrate. So I always make sure that I have a scout so I can calibrate it against one of these other bones. But it basically was narrowed at the narrowest part. It was down to 3 millimeters. And then a little bit of upstream dilation. So this was related to STDs, and the patient was having urinary retention and even reflux into one of the kidneys. They had already had one laser dilation. Laser dilation has about a 50% chance of success. But even despite that laser dilation, it had recurred, as we see here. So they are planning for a urethroplasty. That also is better if you have a longer segment like this, like about 2 centimeters. And they use the inside of your cheek, so your buccal mucosa. They actually will do 4 weeks of urethral rest. So they put in a suprapubic Foley catheter, rest your urethra for 4 weeks, and then they reconstruct that part with buccal mucosa. And then for extra credit, does anyone know what this little line is?
Copus gland? Or...
Yeah, that's the duct for the Cowper's gland. So that's just reflux into a normal Cowper's gland duct. And then the Cowper's gland is like a flower-shaped kind of gland here that creates lubricant that lubricates this bulbar urethra. So don't mistake this for a leak. This is just normal reflux into the Cowper's gland.
Okay, this is a young person, relatively middle age, with rectal cancer, colorectal cancer, and on CT they saw, a solitary big met, and they recommended that. Actually, I don't know if they recommended, but for reasons that they decided to get this MRI as a follow-up. So, you can see this is the, let me just enlarge you can see that the met that we saw on CT is, is there, very big, aggressive looking. So the reason I'm showing you is that as I was reading it, there's something here, right? On DWI, the original met was diffusion restriction, but that area is just obscured by, it's often obscured on DWI. And then here we go on arterial phase, you can see that this thing is getting ring enhancement. And on CT, I'll go back and try to find it, sort of is there, but it was not called, and I don't think I would call it easy to miss. And then, so, for this, this one is very important, right? Because now you have a bilobar disease, which may affect, surgery planning. Another finding is right here. You can see that there's another little space occupying lesion right there. Can't really see it on contrast, maybe it's here, but definitely here on diffusion. There's a little diffusion restriction, and then there it is on T2. There's definitely a, what do you call it? A third little metastasis.
Yeah, this is a great example of how MRI can really help more than CT
right.
sometimes for colorectal liver staging. And diffusion I love because it really like pops out on diffusion, whereas you could really miss those small ones on other phases. The one at the
right.
dome, it was like sometimes that's a tricky area for diffusion, like you lose your diffusion, but it looked like in yours you still saw a little bit.
I don't think so, because here I think that area is completely obscured. I don't know if you can call this, I think this is just more of a factual, but we clearly saw it on arterial phase, like, right? So there's enough evidence to show that this is real, right? On T2, again, it's hard to see what's here. I don't know if this is it. This may be it. So again, like, you can argue that if we miss this little thing on CT, is not a big deal. Probably they would catch it when they would take out, resect it, but this would need like a separate wedge resection if they were doing resect. So yeah, so this is very helpful in these patients.
Yeah, one like slight backup is that or at least our surgeons do intraoperative ultrasound of the entire liver when they go in. So sometimes they do catch these additional lesions, right, and ask us to like call from the OR and ask us to look again. And if we see anything tiny there, they'll go after it. So this would still not preclude surgery. You could still do like a right apopectomy on the edge on the left. Yeah.
So at MSK, they do a lot of like almost like a whack-a-mole, like where they will just do metastasectomies and like, so a long time ago, a relatively longer time ago, this would be prohibitive to resection. They would not touch it surgically. Nowadays, they do segmentectomies, but it is an important thing to know ahead of time, especially like, again, This one is relatively large, and you're right, they probably would pick it up on ultrasound, except that it is in a very funny location. So it's possible they may not. But imagine if there was like a little net here somewhere, right? That they would be very difficult to pick up on, even on ultrasound. So yeah, so this is a better study to pick all of these up. And again, like if they're doing very localized resection, this also needs to be kind of.
Yeah, and just for the residents, so when we do these stagings for colorectal liver metastases, our goal is to try to, their goal is to try to clear the liver of tumor. So we have to describe every lesion. But their goal is also to if most of them are on the right side, maybe they could do a right hepatectomy and then ablate or do wedge resections on the left side. So important things also to describe are any relationship between the dominant lesions and the central, the portal vein. So for example, this one, we describe it's not touching the left portal vein or the left hepatic artery, therefore the future liver remnant is okay. And then also the volume of the liver. So this left lobe looks nice and huge. So they'd be able to cut out the right lobe and still have at least 30% of the liver left. Okay, this is for, you guys do not musculoskeletal, right? Over at Arkansas. So this is an MSK case.
Our fellow is here. She does a lot of MSK. I don't do much MSK, but yeah, she's here.
Okay, so don't focus on this mildly enlarged prostate. Focus on the musculoskeletal structures. I'll put it on bone windows. What do you think? I can't hear you if you're speaking.
Avian, right? Avian. Yeah. Your collection.
Yeah.
Okay, speak up. What'd you say?
Yeah.
My name is Nivedita.
Mm-hmm.
There's a lot of collection around the left hip joint with the air foci seen in the in the femur head and even in the extra-osseous
Yep.
space.
So there's air in the bone and then a fluid collection around the hip with air in it. Yep.
Is it like an osteomyelitis?
Yeah. So this is what's called emphysematous osteomyelitis. And I'd never seen this before, where there's actually gas-forming organisms in the bone. There's some echo, so if you could just mute, that would be helpful. So anyway, this is emphysematous osteomyelitis. It's gas-forming organisms in the bone. It's very rare. On Radiopedia, it says it's case reportable. There's a lot of inflammation around it. It's usually caused by E. coli, Klebsiella pneumoniae, or Fusobacterium. In our case, this patient actually had a Salmonella UTI, and this was on Salmonella bacteremia that had seeded the bone. And interestingly, they also got a PET, and you can see that, there's a lot of activity in the bone, but tons of activity in that fluid collection around it and going down into the muscle. And it's actually just much more extensive than we can really appreciate on the CT. They ended up debriding all of this. And then also debriding, they had infection in their knees as well. And they debrided all of this and went home on IV antibiotics. So they did okay. But anyway, this is just a rare case of emphysematous osteomyelitis.
This is wild case, Aarti.
Yeah. When we showed it in our interesting case conference, that somebody had just had another case of it. So I guess they always come in pairs, but it is pretty rare. Usually the bone is quite resistant. Although, you always can get vertebral body. That it's more common in the vertebral bodies. This is even more rare.
And no history, just.
Seems like they have a history of a shunt, like a VP shunt that is dissected into their liver capsule with a fluid collection.
Exactly, yeah, spot on. Yeah, that was it. I mean, I thought usually we see CSF in the peritoneal CSF pseudosis, but hepatic subcapsular CSF cirrhosis is something like really not very usual, like uncommon. So I thought I'll show this. Yeah.
Yeah, I don't know if it was your group. Someone showed a similar case recently, and yeah, they explained that you can get these CSFomas in the abdomen, but it's rare in these locations. But when it's in the subcapsular region, it can cause all this mass effect on the liver, pain. It can actually rupture.
Right,
So,
yeah.
yep. So focus on the pancreas. What do you think? Hello?
Is it like an IPMN?
Yeah. So this is a main duct IPMN. You can see that there's this big dilation here, and then it goes all the way to the ampulla. So this would be that fish mouth appearance on EGD with a bulging of the ampulla. I'll show you on coronal as well. So here you can see it going all the way to the ampulla, also with some dilated side branches. The rest of the gland, what do you think about the rest of this gland?
It's like ectatic, and there is side branch. Or is there, I think side branches are like ectatic and prominent, dilated.
Yeah, they are, but it's more like kind of ratty looking as opposed to like really engorged and so this is actually more of like a chronic pancreatitis picture. You can see that the gland is really dark and fibrotic here with these raggedy little side branches. So these actually frequently go together. You can imagine if your main duct is obstructed with mucin, that the rest of the gland is going to become, chronically inflamed because it's obstructed. And so you often get like a main duct IPMN along with chronic pancreatitis. If they can resect it, then, there's hopefully still some endocrine, exocrine function in the rest of this gland. Okay, so they went to try to resect this main duct IPMN, and they had to abort the Whipple because there was so much pancreatitis and inflammation that they could not peel it off of the SMV. So they ended up aborting the Whipple and decided to just kind of monitor the patient. And then a few years later, the patient came back, and this is what it looks like now. So you can see that it's bigger. But do you see anything else? So that is super engorged. Lots of dilated side branches. So there's a lot of now evil gray that is encasing the flow void of the SMA and even up here in the celiac axis and going into the portal hilum here. And then the portal vein is also almost basically obstructed. So anytime you're like monitoring post-Whipple or pre-Whipple and there's a change in your vein, you should be highly suspicious that tumor has obstructed it. So here's the SMV coming up, and then it basically just gets clobbered in here with all of these collateral vessels. And then, the intrahepatic portal veins are kind of reconstructed there. So anyway, this was, a patient who had a main duct IPMN, aborted Whipple, and then on surveillance, we can see that there is now invasive adenocarcinoma that is encasing the vessels and obliterating the portal vein. So just a real-time malignant degeneration of an IPMN. We know that main ducts are more risky. And yeah, that was that. Okay, this is my next case. Patient was having epigastric pain, nausea, vomiting.
Stomach wall
Is it like
wall is thickened. I mean, stomach pyloric region is thickened.
So we've got a lot of thickening of like the antrum and pylorus. What do you think that is?
Is it like linitis plastica?
Yes, exactly. So, and we've got some upstream debris in the stomach and like relative obstruction. But we've got this really densely enhancing thickened wall here. So, there was a question like, could this just be severe gastritis? Gastritis, maybe you'll see more submucosal edema, but this really densely enhancing wall with like basically luminal narrowing and upstream obstruction is much more concerning for linitis plastica. And then
Nodes also, right? Maybe subtle, no, perigastric nodes, not sure.
Yeah, exactly. So there's actually soft tissue along these gastric vessels here going into the omentum. And if it was just this, we could say like, oh, there's direct extension into the omentum. We wouldn't necessarily call it peritoneal disease. But if you go further down, you can see that all of this peritoneum is blurry and nodular. So this is actually highly suspicious for peritoneal disease as well. So they ended up going for EGD with biopsies and EUS, and they said it was at least a T3 lesion. And then they went for a laparoscopic staging, and there was extensive peritoneal disease. The path came back poorly differentiated diffuse type gastric cancer. So they are now going to be on chemo as well as some immunotherapies. They're actually doing like a workup, a genetic workup. But just to talk about the two different main types of gastric cancer, there's the intestinal type. That's the main, most common type. Those are seen more in older male patients and are highly associated with H. pylori, as well as alcohol and tobacco. They can be mass forming, less likely infiltrative. And then the other type is called the diffuse type. These are more genetic and especially related to CDH1 mutations. And they are more frequently seen in younger females. And this patient was a younger female. And these ones are more likely to be poorly differentiated, signet ring cell, et cetera. So they often will test them for CDH1. If a patient already is known to have a CDH1 mutation, they sometimes will even do a preemptive gastrectomy. I'll just show you on the coronal. So here it is on the coronal. And that peritoneal disease.
Nice.
Okay. Focus on the right colon and tell me what you think about this area on the right colon here. This actually was a young patient, but they had a lot of vascular disease. I don't remember exactly why. You can see their aorta. They even have thrombus here. And they were doing a runoff study. And then incidentally, they found this in the right colon. What do you guys think this is? Where do you think it's located? Hello?
Aarti, can you show coronals?
Yeah. Oops. Okay, there it is on the coronal. I'll try to. Oops. Sorry. It's right there on the coronal. I'm not going to try to move this because it will mess it up.
It looks like an exophytic mass from the...
Yeah, right? It doesn't really look like a typical mucosal base like adenocarcinoma. It looks either submucosal or possibly serosal, like you're saying, like exophytic to the colon. And so when we think about submucosal masses, sometimes we think about GIST tumors. We think about maybe neuroendocrine tumor, although often we don't see the primary in the bowel. So GIST is a big one that comes to mind. Interestingly, this was actually a dual energy scan, and this was the virtual unenhanced. And you can see, this is like the iodine map, that we don't really see enhancement within it. But anyway, the patient ended up getting an MRI to further evaluate this. And I'll just show you a couple of the sequences from the MRI. So here's our lesion. So what do you think about it now? This is the pre-contrast.
Like a hematoma?
Exactly, right? It looks super T1 bright with that kind of more denser rim or more hyperintense rim. And then on the arterial phase, it was still a little bright, but then when we go to our subtractions, it was basically black. So it was just a hematoma. And I showed you that that patient like had a lot of vascular disease. They even had a critical limb ischemia. And so they were on anticoagulation. And so we think that this was actually just a spontaneous submucosal hematoma just from their anticoagulation. Kind of rare, but it even kind of looked like that on the CT, like kind of bland looking. So, don't jump to the conclusion that every mass affiliated with the colon is a tumor necessarily. This kind of looks more kind of bland looking like a hematoma. And especially patients on anticoagulation, they can kind of bleed wherever. So they ended up actually doing a colonoscopy and biopsy, and this was negative. So what do you think about the pelvis here? We can ignore this. This was just like a Bartholin cyst in the perineum. What do you think about this fluid-filled structure here? So this is the fluid-filled vagina, and it's actually contiguous with this tubular structure right here that is going along the expected course of the ureter. And so if we look back, we had some prior imaging that showed, there was a kidney here, but there was a really atrophic upper pole moiety with a dilated ureter here. So this was a nice Weigert-Meyer rule. So there's a sort of a duplex or duplicated kidney here. And the upper pole is exerting ectopically on the vagina and therefore was obstructed and caused chronic severe hydronephrosis and then eventually atrophy of that upper pole moiety. So this usually in Weigert-Meyer, the upper pole moiety is ectopically inserting and obstructs, and the lower pole refluxes. This case, we don't really see reflux, but you can get that drooping lily sign on fluoro, and you can get reflux in the lower pole. So this was just kind of acute case where we saw that atrophic upper pole from the chronic reflux or chronic obstruction, and then the lower pole here was inserting on the vagina ectopically. It can insert anywhere. It can insert in different parts of the bladder. It can insert on the urethra. I've seen that, and vagina, etc. So